have an amazing staff in CPS. I would like to publicly thank you guys for all the hard work that you put in. I'd like to thank you for being on me. I'm actually like triple booked tonight, but Maria won't let me get away, so I'm glad that I'm here. As we raise awareness to antimicrobial resistance, AMR, it is very important that we educate not only ourselves, but the populations on the effects of overdosing of antibiotics. The body is an amazing thing. The body can adjust, the body can adapt. And what happens with AMR is when the body adapts, the antibiotics no longer become effective. And with that, it can prolong curing, probably even cause death. And I think it's time that, well, the world has it as a global health issue. St. Maarten is joining the fight. We are raising awareness, and I think we need to continue to raise awareness on infection preparedness, continue to promote hygiene, washing of hands, preventative measures, and basically it's just to our population have, as Minister of Health and dealing with 𝒂𝒐, I realized that we have a population that is accustomed, and I see we have a lot of GPs in here, that is goes to the doctor's office and walk out with a bag of medicine. And that's a customary, and that makes them feel good. You just look around the house, and it's just a bunch of medicine that they take continuously. And that is why it's important when you see antibiotics, they give you a specific amount of days to take these antibiotics. And, and we abuse it. We take it, we stop, and we decide to go and continue. So this is a very, very, very good, interesting seminar, very good program. And as we notice the World AMR Week, better known as WOW, I would like to thank you for having me here as your Minister of Public Health, Social Development and Labor. It is definitely an honor, and I look forward that all the stakeholders in this building can come forward with some fruitful information that would help us protect our public, not only in St. Maarten, but as far as we can reach. So thank you once again. Thank you for having me. All right.
Thank you very much, Minister. And so when Maria Henry contacted SxM to see if we wanted to co-sponsor this together with the other partners, CPS, the Medical Center, and the Pharmacy Association, and AUC, we said, of course, this is one of the reasons we exist, and this is part of our mission here at SxM. This evening's moderator happens to be the University of St. Maarten's first PhD researcher. That is Ms. Lisanne Charles, who just began last year to participate in what we call the Islanders at the Helm Research Program, which is a 5-year-long research program whereby she'll be looking into policy development for hurricane preparedness. We thought that it would be very appropriate for Lisanne to join us this evening as moderator because of her knowledge and experience both inside and outside of government, as well as in policy development, whether it be in sports, whether it be in health, whether it be in education. And we thought that her engagement in this group would definitely be appropriate and beneficial for everyone. And we know that we've had her moderate quite a few times this semester, so she's just as tired as the rest of us who have been here this week, who've spent the full entire day. But I ask you to welcome Ms. Lisanne Charles, and she'll moderate the rest of the evening and introduce our guest. Thank you.
Good evening, Minister Otley, official guests, presenters, all. The University of St. Maarten, Ministry of Public Health, Social Development, and Labor, in particular Collective Preventative Services, Pharmacy Association of St. Maarten, and the American University of the Caribbean School of Medicine is pleased to welcome you to this event in commemoration of World Antimicrobial Awareness Week. My name is Lisanne Charles, and I am a PhD researcher with the Islanders at the Helm, stationed here at the University of St. Maarten. And tonight, I am, as Dr. Kamuna would have said, your moderator. Tonight's program is actually part of a worldwide campaign to educate people about antimicrobial resistance, AMR. This campaign includes free and easily accessible online and/or in-person courses, webinars, presentations, lectures, and panel discussions taking place across Africa, Europe, Asia, West Asia, formerly the Middle East, and the Americas. When the week, which this year spans from November 18th to November 18th to 24th was created, the intention was to have a global campaign that is celebrated annually to improve awareness and understanding of AMR and encourage best practices amongst the public, health stakeholders, and policymakers who all play a critical role in reducing the further emergence and spread of AMR. This is according to the WHO website. I always want to say WHO for some reason, but it's definitely WHO. So some of you may be asking yourself, what is AMR? According to the World Health Organization, antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, making infections harder to treat and increasing the risk of disease spread, severe illness, and death. As a result of drug resistance, antibiotics and other antimicrobial medicines become ineffective and infections become increasingly difficult or impossible to treat. Antimicrobial resistance is increasing globally due to increased prescription and dispensing of antibiotic drugs. Estimates are that 700,000 to several million deaths result per year and continues to pose a major public health threat worldwide. Each year in the United States, at least 2.8 million people become infected with bacteria that are resistant to antibiotics, and at least 35,000 people die. And $55 billion is increased in healthcare costs and loss of productivity. According to the World Health Organization estimates, 350 million deaths could be caused by AMR by 2050. By then, the yearly death toll will be 10 million. This is according to a United Nations report. There are public calls for global collective action to address the threat that include proposals for international treaties on antimicrobial resistance. Worldwide antibiotic resistance is not completely, or the cause of worldwide antibiotic resistance is not completely identified, but poorer countries with weaker healthcare systems are more affected. Because of this, also according to WHO, a global action plan to tackle the growing problem of resistance to antibiotics and other antimicrobial medicines was endorsed at the 68th World Health Assembly in May 2015. One of the key objectives of the plan is to improve awareness and understanding of AMR through effective communication, education, and training, which is why we're all here tonight. So tonight we have a full schedule, and I hope you're all ready to be fully informed, and also to ask questions after in our question and answer segment. So we've already heard from the minister, and now I would like to have the first of our 4 speakers for this evening, who is Dr. 𝒂𝒄𝒉, who will offer a medical perspective on AMR. Dr. Kalkidan 𝒂𝒄𝒉, an actively practicing physician on St. Maarten for the past 15 years, joined the AUC family as a visiting faculty member in 2016. She was appointed to full-time faculty in July 2020. Dr. 𝒂𝒄𝒉's work has been primarily through the ER team at St. Maarten Medical Center. Her work teaching ER bedside skills grew into a passion for academic medicine, which she has further cultivated at AUC. With an interest in disaster medicine, emergency medicine, and caring for the underserved, Dr. 𝒂𝒄𝒉 has been involved in island-wide public health initiatives, including participating in St. Maarten's med evacuation team. She managed a local air ambulance company for many years as a medical doctor and med evac doctor of ICU patients, which involved transporting and managing critical patients. Dr. 𝒂𝒄𝒉 is actively involved in the community of St. Maarten along with AUC. She has worked on the island of Anguilla and the Commonwealth of Dominica, where she also did internships after graduating from International Medical School in Havana, Cuba. Dr. 𝒂𝒄𝒉, the floor is now yours, and after you present, you can take one of the seats next to me on the panel.
All right, good evening. So I am going to, a lot has been said, huh? So we're gonna kind of focus on 3 points. First, resistance of antimicrobial. It's a worldwide problem. It's a global health issue. It's not here, it's everywhere. The statistics, I think you gotta kind of put it together very well. So that meaning, what that translates is we're gonna have a problem with simple pneumonias, with simple gonorrheas, with simple infections that are gonna end up really mortal. Okay, good. Yeah. I can come closer. Can you hear me now? Yeah, sure. So let's address this issue. Let me just kind of point out, we kind of call it a post-antibiotic era. We're gonna bring these key points. It's a big threat. It's a huge threat. We're not aware of it. So this is, I'm very grateful of this initiative because it's gonna come very hard on us. It happens even if you're not aware, but the misuse of antibiotic, it speeds the process. So it's coming faster than expected. It's a global health issue. It affects everyone. It doesn't matter the age, the race, the gender, doesn't matter. And by the way, it's not only human problem, it's also animal problem. Yep. So what are we gonna do? It happens, but we are, without being aware of it, it's gonna come on faster than expected. So what that translates, it translates so we cannot simply treat the simple infection with a simple way. So this patient, what's gonna happen? They're not gonna get better. They're gonna get hospitalized. They even may die. So the expense is gonna go higher. We're gonna lose a lot of people, and we will not be able to treat simple infections such as pneumonia, such a wound, cuts, and that got infected when we need it. So this is very important for us to be aware. So what to do about that? So this is to individuals first. We need to know, we need to ask our healthcare providers, or we need to go to the doctor when we are sick. So it has to come from a healthcare provider, not from us, which it happens a lot, yeah? Never demand antibiotics. We need to listen, we need to say, we need to understand, do I need an antibiotic? What did the doctor tell me? Always follow instruction. Our pharmacy, I really appreciate, there's a big group of pharmacy here, and I know them very well because, not the back group, but, yeah, thank you. I'm so sorry, maybe I can hold it. Yeah. So, at least I know very well Natasha. When we have a question, we communicate. They would call us, they would ask us, is this what you meant? Do you really? So it's not a bad idea, don't feel any way. So, and they also give a proper instruction to the patients. So the patient, we need to follow up. What did the doctor say? What did the pharmacy say? Especially finish the course, which also is the problem. So what happened to our patients most of the time? We are so caught up with daily life, with multiple jobs. I have patients come in and say, Doc, tomorrow I have to feel better. It's a must. You gotta give me some antibiotics, give me any prescription you want, but I gotta feel better tomorrow. And how do we do that? It's just so difficult. So we need to emphasize that that falls under individual. What else individual can do? Prevent infections. The same thing, COVID taught us so many things. So from hygiene, washing hands, if you have a flu, you may have to stay home and wear mask, look at the guidelines and so on. this is what individual can do. What can healthcare provider do? We can do. We need to provide to our patients a safe, clean environment. So maintain our clinics properly, safe, free of infection. Again, COVID taught us a lot. Keep all the instruments, everything hygienic, have more cleaning, have more venting, have more all these things. I personally, I like a lot of appointments for one of these purposes. So I do very early, especially the vulnerable ones, elderly patients and so on, and then later down, and I avoid crowd in the waiting area. So this is one of the reasons. What else we can do? We have to report the resistance of the antibiotics. If we see that someone did not respond the way we wanted them to respond or expected them to respond, we should report it for the research purposes, which is I'm very happy. For the surveillance, that's how we can improve things. If we have data, if we have research, if we have any numbers, that's the only way we can improve things, yeah? Again, and then for the healthcare industry or for policymakers, I am very happy that's what I heard today, but I can say the investment need to be made for research. Absolutely. So if we don't have data, there's nothing you can make a conclusion. If you don't have research, there's nothing we can make a conclusion of it. As we said, those are the key points that we need to pay attention to: the individual, to the healthcare provider, and to the healthcare industry in general, which include the policy, the surveillance, the pharmacy, and again, we cannot do anything by ourselves, but together we are able to come up stronger and address the issues better. Yeah. And this meant to be for audience, so for the public, and I'm gonna take any questions about antibiotics resistance or any experience I have in my practice, yeah? Thank you so much.
Thank you very much.
Thank you very much, Dr. 𝒂𝒄𝒉, for your presentation, and also, of course, for highlighting why this resistance is going to become an issue for us, but also why individual medical professional and sure it was.
Dr. 𝒚𝒐𝒖𝒓 joined AUC from the University of the West Indies in Trinidad and Tobago, where he was senior lecturer in pharmacology at the Faculty of Medical Sciences. Prior to that, he was an assistant professor for 3 years at the College of Pharmacy, Qatar University, where he was the sole pharmacologist in their program. He moved to Qatar after helping to establish the pharmacy program at Kuwait University, where he was a founding member of the Department of Pharmacy Practice. Dr. 𝒚𝒐𝒖𝒓 also taught in the Department of Applied Therapeutics. He was instrumental in developing the practice and therapeutics curricula, and was also officer for the Continuing Education and Maintenance of Professional Competence program for practicing pharmacists. In addition to a bachelor's and a PhD degree in pharmaceutical sciences, pharmacology, from the University of Alberta in Edmonton, Canada, Dr. 𝒚𝒐𝒖𝒓 holds a bachelor's in animal biology and psychology, and a Bachelor of Arts degree from the University of Calgary. He did a 1-year postdoctoral fellowship at the University of Alberta before joining the Division of Endocrinology and Metabolism at the Faculty of Medicine, there as a research associate for 7 years. Dr. 𝒚𝒐𝒖𝒓 is a registered pharmacist with the Alberta College of Pharmacists and has practiced pharmacy in the hospital and community settings for over 15 years. In addition to teaching, Dr. 𝒚𝒐𝒖𝒓 is interested in several areas of research. His primary interests include pharmacological and biochemical studies of intra- and intercellular signaling processes involving protein, this word I do not know, I was pondering it all day, kinase, and the potential role of dietary supplementation with plant-derived antioxidant compounds in chronic disease conditions. Dr. 𝒚𝒐𝒖𝒓 joined the AUC faculty in June 2012. Dr. 𝒚𝒐𝒖𝒓, the podium is now yours.
Thank you for that extensive introduction about my background. I am Canadian. I'm originally from Zimbabwe. And I moved to Canada when I was 14 years old with my family. And I essentially grew up in Canada then. I've been in St. Maarten now for 10 years. It was 10 years last June. And I'm really happy to be here. When I first arrived, the dean at AUC didn't think that I was going to last a year. And well, here I am, almost 11 years now, and I'm still here. So it means that I like this country, and I like what it has to offer. And looking at the audience, I see one of my tennis buddies here. So it's really nice to have people in the community that you know, and people that you can relate to. I'm going to be talking a little bit about the significance of antimicrobial resistance, and I'll give you a couple of examples. Do we have a pointer? This is the pointer, right? Yeah, okay, thank you. All right. So, antimicrobial resistance is supposedly one of the top 10 health threats to the public in terms of where we are at today. And going forward, as you've heard from the other speakers, the previous speakers, it's going to be a much bigger problem. And by 2050, it's going to cost us, I'll show you some of the statistics, okay? So the development of resistance in bugs is not just in humans, it's problematic in animals as well. And what we do, and one of the things that I was thinking the audience would comprise of would be lay people. And I wanted to address those as well, because a lot of the times people don't realize how their lifestyles, how they take things maybe so casually, can actually have long-term effects on not just our community, but worldwide. So the use of antimicrobials, of course, is prevalent when we are treating people who are sick, but we also have animals. Animals provide us food, and animals provide us companionship. Those animals get sick, and we are essentially in the same biome, we're in the same environment, we are doing a lot of things together with the animals. And then, of course, we do eat some of the animals, And when the animals are exposed to antimicrobials, we know that this year we reached a milestone in human population. Now we have 8 billion people in the world, okay? So that is very significant. Why? Because with 8 billion people in the population continuing to increase, there's going to be a greater demand for food. How do we improve our food supplies? Well, one of the ways that we have done so, and we're continuing to do, is to make sure that when we are raising animals, animal husbandry, we use agents that are going to enhance their growth and to make sure that they're safe for public consumption. That means that we're also going to use antibiotics in animals. So there are consequences to everything that we do. Now, there is a lot of different sources of food, including fish. Fish farming has become very widespread. The other issue that I want to point out, and I'm not really going to follow what I've put on there, I like speaking like more naturally. And when we look at farming and animal husbandry and fish farming, fish live in water. We have actually dammed off areas of the ocean where we have fish farms. They are treated with antibiotics. Where do those antibiotics end up? In the water. They affect other animals, sea creatures that we consume as well. And we can actually pass resistance from animals to humans. And I'm going to show a little bit of that towards the end. So there are a variety of different things that we need to do. But before we do that, let's just look at our use as humans of antimicrobials and see where we are at. This is a paper that was actually done, a study in Africa, okay, in the Journal of Microbiology, 2016. And they were looking at antimicrobial resistance, and most of you, if not all of you, are healthcare people with good training, so you know and you recognize some of those antibiotics, if not all of them. But look at what happened. This is within one community. Ampicillin, almost 79% resistant isolates, okay? Cotrimoxazole, a drug that was very widely used, maybe not so much anymore. That's Bactrim, by the way, brand name, yeah? Urinary tract infections, over 60% resistance. This is just within one community. Now, if you can extrapolate that to what's happening worldwide, it's really frightening. Because if we get this type of resistance, what it means is that we're going to lose the use of those antibiotics. And when we lose them, it's going to have consequences on the entire society. Why? The bugs that are resistant can be passed on more easily to other people, and they're going to be infecting other people. They're going to affect healthcare costs, and they're going to cause a lot of morbidity and mortality. So we have a lot of things that and these are just examples. I don't want to really go into a lot of detail about these things, just to show you what can happen. And I mentioned animal husbandry, okay? In this slide, it's showing, does anybody know what a transposon is? Yeah, okay. Transposons are supposedly jumping genes. We've heard about zoonosis, and we've had a number of, including supposedly maybe COVID, supposedly having come out of a market somewhere in China from animals, right? And it was a zoonotic disease, maybe. Maybe it wasn't a disease in those animals. But when it came into the human population, it became disastrous for all of us. If we can look at the consequences of that in terms of how many people died before the vaccines, and how many people maybe are still dying, and how many people are suffering the after effects of having COVID, the so-called long COVID syndrome, right? So if we look at this, we can actually see in the top left panel, resistance to beta-lactams, which include cephalosporins and penicillins, and then related antibiotics that have the same beta-lactam ring. And around that circle is indicating human communities, animals, including chickens that we eat, many of us maybe 2-3 times a week, right? And other animals. And those lines that are colored, that are going in between, is essentially showing how genes jump from one species or from one community to another, okay? So beta-lactams, tetracyclines have been used for a long time. In fact, one of my favorite antibiotics when I visit Africa for prevention of malaria is doxycycline. I take it once a day, and as long as I take it, I've never been sick with malaria. So I really like that. But tetracyclines, pretty much the same thing. Aminoglycosides, the panel on the bottom, shows essentially the same sort of interrelationships. So what can we do about this? Well, there are a number of things that we can do, but before I go on with this, there is one other very serious threat that I think we really need to be worried about, and that is Mycobacterium tuberculosis. Mycobacterium tuberculosis infects maybe up to about more than half of the world's population, okay? It's what used to be called latent TB, and some people live with it for a lifetime without ever getting the disease. Other people, if their immunity goes down, what happens? They get sick. And TB is a serious disease condition. It kills many people. So when we look at resistance in Mycobacterium tuberculosis, we have two types of resistance. You can actually get infected by somebody who has a bug that is already resistant, or when you are being treated for TB, you can actually acquire, by not taking the drug on a regular basis, you can actually develop, the bug can actually develop resistance. So it's two types of resistance. And in this little panel, what it's showing is essentially, if you look at all the population of people who have TB, and the inner ovals are essentially showing drug resistance according to the degree of resistance, okay? So the outer oval, all TB, the next oval, any resistance to any drug that is used to treat TB. And then it gets really complicated because we get multi-drug resistant TB, and it becomes more difficult to treat. When it becomes more difficult to treat, it means that normally TB, when it's sensitive, the duration of treatment is for a minimum of 6 months. You get 2 months with combination, usually 4 drugs, okay? And then after the 2 months, you continue with the most active drugs, usually for another 4 months, total 6 months. When you have resistance, now you have to look at why, what is the bug resistant to? You isolate that, you discontinue it, and you have to add on newer drugs, which is going to add, first of all, more cost to the therapy, as well, it's going to increase the duration of treatment. So this becomes a really difficult problem for the world. In developing countries, I'm originally from Zimbabwe, as I mentioned, and in Zimbabwe, during the AIDS epidemic in the late 80s and early 90s, in most of Africa, if you went to many villages, there were no people between the ages of about maybe 17, 18, and maybe 40 or 50. Most of the people were kids or the kids' grandparents. They had survived the AIDS epidemic. Now, what happened was that many of those kids who were born during that period, of course, also acquired the infection. As we know, AIDS decreases immunity. So treatment of TB in somebody with AIDS is going to be more complicated, okay? Fortunately, most of the TB in those patients was not drug resistant. But because of the poor health conditions and resource-poor situations in those countries, many of these people sometimes would only get treated for a little bit of time, and then they would not show up to get their, maybe the next month's drugs, or they would not show up to the clinic where they needed to have directly observed therapy. That allows resistance to develop. Okay? So, multi-drug resistant TB is a lot more difficult to treat. I'll give you a little story. In 2007, there was an American guy who wanted to get married. He had TB, and he decided that he was going to get married in Italy, in Europe. He traveled with his prospective spouse, got there, but this guy did not have MDR, multi-drug resistant TB. He had extensively drug-resistant TB. What is the implication? For somebody with MDR TB, the duration of treatment is usually about maybe a year, 9 months to a year. With extensively drug-resistant, it goes up to about 2 years. Okay? So it's a lot longer. Usually somebody contracts extensively drug-resistant TB, they have to be quarantined. Why? They can pass on the infection more easily. It gets into the community, and you get people who are going to be infected, and you're going to have that duration of treatment for those people for 2 years. It's going to be more difficult because controlling them is going to be difficult. This guy was supposed to be in quarantine, or he was supposed to be staying at home in isolation. He traveled to Italy, got to Italy, and of course they found out in the US. I think he was from Georgia, I think. And when he was there in Europe, in Italy, he decided, well, he got married and he had his fun and he needed to get back home. Well, they had put out a warrant for his arrest. This is in 2007 in the US. And the guy thought, well, if I fly back to the US, guess what? I'll be arrested at the airport. And in fact, the US government had told him not to come back, but to stay in Italy and get treated there. Well, he did not. He decided to travel back, and he did not travel back on American Airlines. He actually took a Czech airline to Canada and then drove across the border. Drove to New York, gave himself up, and he was quarantined. Okay? So it shows how serious these infections can be. And if they're that serious and they get out into the community, think about the cost. Think about the implications for the community. Okay? So what do we need to do? Well, I talked about this, and you know the drugs, so I'm not going to go through that. But consequences. Okay? Prolonged illness, as I mentioned, treatment duration is going to be for XDR-TB 24 months at least, if not longer. Okay? We're going to have people actually needing very specific care that is highly demanding of resources. There will be a need for hospitalization. The illnesses are going to be more complicated, and usually if you have one infection for a long time, you're actually susceptible to other infections. Staying in hospitals is not a safe environment for anybody unless you really look after yourself. And we have hospital-acquired infections, okay? And many of the resistant infections people are actually getting in hospital environments, okay? So the illness is going to be more complicated. It's going to demand more resources, including physicians' time and other healthcare providers. We're going to have newer drugs that are going to be effective, because with multi-drug resistant TB, I mentioned we treat it for 9 months to a year. Well, guess what? If that patient is non-adherent to therapy, they can also develop resistance to the newer drugs that we've added onto their therapy. And if they have XDR-TB, we are really in trouble, okay? So need stronger and more expensive medications, and of course, more people are going to die, okay? This is going to affect not only the healthcare community and the country's resources in terms of demands, even the families that are impacted by having to support those sick people are going to have to pay for that, okay? So it's estimated that by about 2050, 10 million lives a year, okay, are going to be lost. Losing 10 million people, maybe by that time the population will be over 10 billion, so maybe if you say 10 million is, well, but still, think about the impact. Think about the economic impact, because it means that these sick people are not actually able to contribute to the economy. So there are a lot of things that are going to happen. And, sorry, I meant to switch this, and I didn't. But what I was just going to show with that last panel was the number of deaths that are happening today attributable to antimicrobial resistance. Less than 1 million, about 700,000 annually, okay? But by 2050, it's going to rise to about 10 million. That's more than 10 times as much. So what else can we do? Well, I think Dr. Bekele and the other speakers have already alluded to what we can do, right? We need to take care of ourselves, but not only ourselves. I talked about animal husbandry and what we do. One of the key consequences of shucks, did I miss that slide? Oh, I guess I deleted it for the sake of time. But there was a slide that I had. There is a bug called Campylobacter, and Campylobacter affects both humans and animals. And it causes a lot of complications in animals. For example, one of them, stillbirths in animals, low birth weight, etc. So if these are animals that we're using for food, think about the cost. Think about the implications long term. You get this resistant bug, it's circulating among animals. I already mentioned the biome that we live in, that includes the animals that we have. So all those things are actually going to affect and impact us. So we need to change. We as healthcare providers or professionals, we know the consequences. Do the people out there know? No. We need to educate the population. That is one of the key things that we need to do. When I was in Kuwait, I did a study with some of my students and colleagues on disposal of medicines from home, okay? It was mentioned earlier that people get these medicines, they accumulate them, and they keep them, and they share them amongst other people with family members, etc. And when they dispose of them, well, usually they just throw them in the garbage, right? Where do they end up? Well, they're going to end up in our water systems, they're going to end up in our environment. We are going to actually expose bugs that were sensitive initially to low concentrations of these. Bugs are very smart. They develop resistance, okay? So key things that we need to do is to be very careful about how we handle medicines, not just antimicrobials, but all medicines. There are other medicines that, for example, impact fish, yeah? And environmental toxicants, for example, plastics, that are found to produce substances that tend to alter genome, if you wish, in animals. Feminization, because they emulate hormones when plastics break down. So just making sure that we have adequate disposal systems, we have safe water, we have good, clean environments that we live in. And I think that message to us is clear. Is it clear to everybody out there? Maybe not. And I think maybe we need to make more of an effort to actually educate the public. Thank you.
Thank you very much, Dr. 𝒚𝒐𝒕𝒉𝒆𝒏𝒊𝒏𝒈, for your informative presentation, which made a strong case for the fact that we do need action on this matter right now, including on St. Maarten, and of course made the link between increased resistance in both animals and humans, and why the latter will also impact the former, and what we need to do as a result of that. Right now, we will go over to our third presenter, who will inform us about the local AMR reality. Sabina Vollenbroek is a pharmacist at the public pharmacy Simpson Bay Pharmacy. She studied pharmacy at the University of Groningen in the Netherlands and worked as a pharmacist in nuclear medicine in Amsterdam. Ms. Vollenbroek, the podium is now yours.
Thank you for this introduction. Okay, I will discuss this topic with you in relation to the local pharmacies, but a little side note, I will only talk about the antibiotic aspect of AMR. So first of all, some numbers to show how important it is to take action now and not to leave the situation unchecked. Approximately 1.27 million people died in 2019 as a result of antibiotic resistance. If we leave the situation unchecked, in 2050, scientists estimated that almost 10 million people will die worldwide every year. In comparison, in 2019, 864,000 people died, and 643,000 people died of malaria. So what am I going to discuss with you today? First, what do we to prevent AMR as local pharmacists? What can you do to prevent AMR? The correct use of antibiotics, and some cons of taking antibiotics, and the take-home message. So what do we as local pharmacists to prevent antibiotic resistance? If you come to the pharmacist without a prescription and you ask for antibiotics, we will advise you to go to see the doctor first, because the doctor can decide if it's necessary to take antibiotics, because this is not often the case. Sometimes your body can heal on its own without taking any drugs. Also, we control the dose. Sometimes when the dose of the antibiotics is too low, we will discuss this with the doctor if it's necessary to increase it, because a too low dose will stimulate resistance, and a too high dose can give more chance for side effects. We also control the interaction with other medication in use. For example, if you use iron tablets and you are taking a 𝑭𝒐𝒍𝒍𝒐𝒘, it will form a complex and it won't be absorbed in your intestine, so both of the medication won't be effective. And also we give you advice for optimal therapeutic use. Some antibiotic, it's better to take it on an empty stomach, and sometimes it's better to avoid antibiotics with combine it with dairy products. So what can you do to prevent AMR? Obviously, the most important thing is to prevent infections. You can do it by washing your hands frequently, keep your wounds clean if you have one, but also cook your food to proper temperatures. So use only antibiotics when it's prescribed by a doctor. Do not share them with your family members or your friends. And do not save them for later, because a couple antibiotic pills won't help your infection, and it only stimulates the development of resistance. And use antibiotics correctly. So how do you use them correctly? Take the prescribed amount at the right time every day. And do not skip any dose. And do you skip accidentally a dose, that happens, you can take the dose as soon as possible, but if it's almost time for the next dose, save the tablet for later, so your cure will be a little longer. And you can always call the pharmacy to check what to do. Always follow the intake instruction given by the pharmacy staff, and never stop a course without checking with a doctor, and also never stop using the antibiotic when you feel better. That's not a good idea. And also a very important point, never leave the antibiotics in the car, because the heat in the car will make the antibiotic ineffective, because most of the medicine you need to store below 25 degrees. So there are also, it's good to be aware of the cons of taking antibiotics. They are not completely harmless. They can give allergic reaction, like an itching skin or a skin rash, but also more severe problems like difficulties with breathing. It's important when you experience these allergic reactions to call your doctor. But allergic reactions are very rare. More often, there are other side effects like diarrhea, headache, or stomach pain. I think we all experience those when we experience those. And of course, the antibiotic resistance problem. So what do you need to remember of this presentation? Only use antibiotics when necessary. Take the antibiotic as prescribed. And if you have questions, don't hesitate, but call your doctor or your pharmacist with the questions. That's it.
Thank you, Ms. Vollenbroek. You certainly painted a picture about the best practices when taking antibiotics, and also, of course, highlighted the cons of taking them, so thank you very much for that. And lastly, before we go over to the questions and answers and discussion section of the program, we have a testimonial from Ms. 𝒚𝒐𝒖𝒓, who will speak to us about her antibiotic experience. Ms. Illis, I have to read your biography, sorry. Ms. Illis is a social worker and artist who is a daughter of St. Martin soil. She is an SGI member practicing Nichiren Daishonin Buddhism and chanting Nam-myoho Renge-kyo. She's a social worker at St. Martin Academy PSVE who loves her students and her job with a passion. Ms. Illis is the founder and president of Victory Over Injustice, Consciously Eliminating Silence, known as the Voices Foundation, which is a nonviolent organization in honor of her late sister, Micheline Douglas Illich, who was brutally murdered by her husband. Nkosazana Illis loves to recite poetry and dance. She also enjoys playing the djembe drum, blowing the conch shell, and giving libation from her calabash to pay tribute, honor, gratitude, and respect to her ancestors. Ms. Illis, the podium is now yours.
Thank you, Lizanne, for that testimonial. But I call it a life-threatening experience, actually. A couple of years ago, I lived in the Netherlands. I went there to study. And the climate in the Netherlands is totally different from the climate in St. Maarten. So in winter, it's very, very, very cold. And I'm a person, you can see I don't like shoes because I love my feet to be on the ground. So of course, in winter, I had a car and my apartment was very close to my garage. So I would wear open shoes, jacket, head covered and scarf. And I felt comfortable. But doing this constantly, I end up with a frontal lobe infection. Yes. So the doctor gave me antibiotics and for like 10 days. So I started taking the antibiotics, and within 5 days, I felt great, not even good. I felt great. So I stopped taking the antibiotics, to be honest. And you know, when you're young and you feel like you know it all, so I knew it all then. So I stopped taking the antibiotics. And I realized, like, maybe after 2 weeks, I mean, not even so long, I started to feel really bad. My bad headaches, like, coming back again. I was like, but no, I'm feeling good. What's happening? So I went back to the doctor. He was like, you know, Miss Illis, did you finish your antibiotics? And I was like, no, I felt good. I didn't see the need to continue. He was like, no, you can't just stop like that. You have to finish, you know, everything. So he gave me stronger antibiotics, which I took. And it took a longer time, but it felt also good. But I decided I'm going to take and finish all of these antibiotics. And I did. But I realized over the years that I kept getting the frontal lobe infection. And I went back on antibiotics. And then I came to St. Maarten to live. And recently, I started, well, not recently, but I started having, like, you know, like headaches and spasm in my head. and the side of my face, I can't touch it, and I was like I felt like something was wrong. So I went back to the doctor, and they sent me to the neurologist, and then I took a test in my head with the electric things in my head. And I got back my results, and the neurologist said to me, we see that you're suffering from small epileptic seizures. I was like, wow. So the person that I am, I'm very spiritual, and I go into myself, and I realize that this has happened because of the causes I make back in the Netherlands when I stopped my antibiotics, because it also, the frontal lobe, I'm getting a little emotional, don't worry about that though. The frontal lobe infection can cause, if it's really bad, it can cause seizures. I mean, I looked at the doctor to, you know, it can cause seizures, you know? And so I realized for myself that sometimes in life, we get ill or we have I call it a dis-ease in our system. Sometimes we don't understand what it is, and that's why the doctors are there for us. And those of you who have faith, put together the right doctor for your right situation, because for me that is very, very important, not just going to a doctor and saying, I'm going to the doctor because it's a doctor. You know, you have to feel that connection with your doctor. Sometimes you go to a doctor and they just hurry you off, and they're quick to give you medication just to get you out of their office because maybe they had a bad day. I'm just saying, I don't know, probably. But I think it's very important to have a good connection and to speak with your doctor. If you don't understand something, to ask a question. Just keep asking, and that's what I do. But because of the result that I got back now, of course I'm not like afraid or scared or this is gonna happen or that, because I ain't dying now, trust me. I got a long way to go, so that's not my situation. But what I wanna say is that for a lot of persons who are taking antibiotics, please finish it. Don't stop halfway like I did. You know, we always say you have to use wisdom, but my elders always say, or my parents always say you have to use common sense as well. So you combine both wisdom and common sense. I learned the hard way. And I can't blame no doctor, I can't blame no one. I take full responsibility. So for me, taking antibiotics meant at that time that I felt good, so I stopped. But now, this time, in these times, I know I have to finish my antibiotics. I'm still not a person who loves to take medication, trust me, because I love to go the natural way. But you have to know the dosage of that as well. So you just can't say, oh, I'm going to take Bush, and then I'm going to worry with a doctor, and I'm going to do that. No, it doesn't work that way either. So for me, it's really understanding my body, understanding what I can take, what I cannot take, when my body have too much or when my body don't have too much. But to really let my doctor know exactly how I am feeling. Because I can't go to the doctor having pain in my hand and tell him my feet is hurting me. He ain't gonna work. Because he's gonna give me medication for my feet and not for my hand. You know, so we really have to be honest with ourselves and honest with the doctor. So for me, taking antibiotics was like a learning life experience, or a threatening life experience, as I would call it, because I learned that when you stop halfway in anything, it doesn't work to just complete the process. Thank you.
Thank you very much, Nkosazana, for your story. It certainly drives home the importance of awareness on this issue, particularly around the proper usage of antibiotics and the duration. And of course, of everyone continuing the hard work of raising awareness about this issue. Of course, incorporating both wisdom and common sense to talk to the people. So we've come to the end of our presentation, but we do have a moment for questions and answers. So if there are persons in the audience, or even if the doctors would like to, or the panelists would like to pose questions to each other, it's possible. If you have a question, just raise your hand and I will come to you with the mic. And now we only have one mic because the first mic faulted us. I see we have our first question, so I will hand you the mic.
Hello, thank you so much for the information, very informative. I had a question for the pharmacist. How should someone dispose of unused medications or old medications that they may have at home? What's the best way? Or for anyone, for that matter.
Well, thank you for this question. And the best way, I think, is to bring it to the pharmacy, and the pharmacy can throw it away. Yes.
That was actually one of my questions, because I think people are not aware that they cannot throw their, exactly, flush it on the toilet, they throw it in the garbage. Exactly. Are there more questions? If not, I have a question, which is actually about, because that's my thing, which is community work and how we can actively engage community members in, processes such as this. So are there strategies already that you all know of about how to actually get the message out in a more stronger way? I know it's like events like this, for example, but are there any initiatives to like go into the community or have pamphlets at the doctor's office or anything online? Yes. Is there anything like that happening?
Okay. Yeah. So we need to put more effort. I would say that we need more, put it out on the radio, put it out pamphlet and lots of messages. And in the offices, we should have inform our clients, patients as well. There's also one thing, individual education is very important. So if I am prescribing an antibiotic, I really have to have a reason why. And I really have to follow the rules, what I'm using first, what's on my first line, what's on my second line. And what if the patient is allergic to this one and cannot tolerate this one? There are a lot of limitations why you can also screen, but it's important to let the patient know. You just don't hand the prescription. You let them know, I am giving you, not for the flu, the antibiotics. By the way, antibiotics are used for a bacteria, right? We don't use them for viruses. So, but we let them know the flu. I'm gonna give you an example, a typical. It also, a lot of, because it's a small community, you hear a lot of different things around, yeah? So it will be like, I'm gone to this doctor when I got very bad flu. They only give me paracetamol. But then I went, I'm not gonna say where, I went to X first, but then I went to Y, day 5, and he gave me a whole bag of medication. Naturally, the flu is passing. Day 5, you should get better, right? No, but they start taking it day 5. That is so bad. That is so bad. I mean, you should not put your body through this. And it's already, if you have any kind of flu or anything that you doubt and is not getting better, the best thing is to return to the doctor that you saw and let them know this is not better and I don't feel better. So they can have the first info when they saw you, and then they have the second info when they saw you. But also this is very important to educate the patients. Yep.
The other thing that I think is critical is surveillance, just keeping on top of the antibiotics that are being used, culture and sensitivity tests, and producing antibiograms that are going to tell us the prevalence of certain maybe resistant bugs within the community and within the hospital. And maybe it's being done here already, I don't know. No, yeah, it is. Oh, excellent. Yeah, okay, good. All right, thank you.
That was one of my questions.
Yeah, so I guess I can elaborate. So the first question that you had about community, I think the beauty of Small Island is collaboration. So we have partnered with AUC, as was mentioned earlier this evening, and we are going to be out at various pharmacies this Saturday, November 26th, working with students from AUC to be available to be there for the public if they have any questions or concerns about specifically the importance of AMR. I don't know if you can maybe hold these two up, but we've developed also some information graphics that we took from the World Health Organization and also branded it locally to highlight not only our partnership, but also the fact that we are committed to promoting the excellence of this hopefully start of a wonderful collaboration. And also to add, we will be sharing this amongst various general practitioner offices so that, when your clients come in, this is hopefully front and center within your clinic so that they can be engaged and informed and have those conversations. So the comment about surveillance, being an epi by training, I am all about data and surveillance. And I will say that the St. Maarten Laboratory Services, our public health lab, has been working on studies and looking at antibiotic resistance, antimicrobial resistance. So hopefully we will continue to partner with them through research, education, collaboration, and hopefully keep on top of what we're seeing locally.
One question for the pharmacist is curiosity, because I really think that the idea of taking back your medications would be incredible, especially if there was like a drop box in each pharmacy and something to let patients know that they can do that. But then what would the pharmacy do to dispose of it? I'm just really curious as what is really the safe way at the end. And then for Dr. 𝒏𝒈𝒕𝒉𝒆𝒏𝒊𝒏𝒈, starting treatment on day 5, why is that harmful?
So the program we have now is that maybe it's not enough out there for patients to know that they can come, so that's something that we should do a bit more. But patients that go to the individual pharmacies usually bring their medication back, and then we store it, and then we have to give a list of those medications to the inspectorate, and together with 𝒐𝒍𝒍𝒐𝒃 and the inspectorate, they plan a day that they dispose of it at the dump. Now, how they do that part, I'm not sure, because we don't go, but that is done with the inspectorate, and then they have a list of what is being disposed of from all pharmacies.
So day 5, so we have a viral infection, which is the most common respiratory tract infection. So the antibiotics won't do anything for the virus, right? So antibiotics will help the bacteria. And most of the flu are viruses. So the natural course is 3 to 5 days. Of course, you can give things to make people feel better, whether it's a cough medicine, whether it's something for fever, a nose spray, or all these things that help a little bit. But an antibiotic won't do nothing. But the day 5, naturally, you're gonna end up feeling better. 3 to 5 days, the flu should pass. If it's not passing, you should come back. You should see back the doctor. There must be a reason why it's longer, and then that can be checked. But people would go to another doctor because the first doctor didn't help. So when you go to another doctor, the other doctor may prescribe an antibiotic. But then you naturally already feel better. It's a course of the disease. And then you say, hey, this worked. And not knowing this is really, really, really bad. And we also have different way of seeing things, and we have to be careful. We have we have to have our own policy how we're going to treat each disease. I'm going to give you an example, ear infection. Ear infection preferably is treated with the topical antibiotics, ear drops, preferably. And then there are a group of kids, if you are very vulnerable, you want to give them oral antibiotics. But ear infection is also, it can be self-limited disease. So it can go away, not always necessarily need antibiotics. But again, it can also create complication, which is meningitis. So it's a tricky situation with the ear infections. Those people take ear infection very lightly. I always want to see them back because I want to see if it's just a very mild inflammatory process and resolve itself, or no, we need to use an antibiotic. Would use preferably topical antibiotics, drops. And then if it's progressing or if there's underlying condition or the patient is vulnerable, then I'll use oral antibiotics. But regardless, whether you treat it or you don't, certain percentage of the patient may end up with meningitis. So we have to have, sometimes like in the US, because of possibility of meningitis, they will automatically, you just have to go on antibiotics because they kind of they don't want the meningitis. But the study have shown that whether you use antibiotic, you may end up with meningitis. So there are lots of things like that. Those are other reasons why you follow up patients that you don't put on antibiotics and so on. Yeah?
So the doctor shopping is really the issue as opposed to following up with your doctor for further response.
Yeah, yeah, yeah.
Okay, thank you.
I have 3 questions. The first one, I see that there is over-the-counter antibiotic creams being sold at pharmacies. Does that create the same resistance? That's one question. The second one is anything done about, veterinarians? Some would, they prescribe antibiotics as well. And then the third one, anything about customs. If you go to the States, you have to have your prescription with you. Now, I lived in Mexico, and at the airport, they would sell you all kinds of antibiotics at 1/10 of the price. And when I would come to St. Maarten, I would stock up on antibiotics because it was so much cheaper than buying them on St. Maarten. Nobody ever checked me when I came in here. I flew to the States and with a patient who had like 10 different pills, and they had to check each of the pills against his prescription. So there they were very strict, but I've never been checked by customs here in the 27 years I live here. So yeah, and I don't take antibiotics anymore, don't worry. But still, my questions.
Okay, so I will just come forward with the mic, and then whoever would like to answer can dive in.
All right. With over-the-counter medications, especially topical antibiotics, many of those are not classified as antibiotics as such. They may be antiseptics. The major difference being that antiseptics will work very quickly to eliminate whatever bug it was. However, we do have, for example, a bug called Staph aureus, and it has become resistant to the beta-lactams, normally called methicillin, that is used to treat it. And we have a drug that has been used, and it's only on prescription, at least in North America. It's called mupirocin. And people can carry that infection that is resistant to penicillins and pass it along. So this drug is actually used to prevent passage of the methicillin-resistant Staph aureus infection to other people. as far as I know, that particular drug, I mean, it's topical. It's only on prescription. I am not really familiar with the medications available here, but my assumption is that it's very similar in Western countries anyway. So that is quite well controlled. However, because we travel and we go to other places, and I know for sure Latin America, in Mexico, for example, you can actually get oral antibiotics without a prescription. That is a danger. And I'm sure drugs like mupirocin are widely available as well, most likely without a prescription. So there's always that danger. The world is a global village. We travel, and we can actually acquire those infections, you know, that may be resistant from elsewhere. I don't know if that answers your question about that. The generics? Or the veterinary meds. Okay, the veterinary meds are really, there is usually no distinction for many medications that we use between humans and between, for example, with COVID, we had this issue about ivermectin, right? Ivermectin is widely used in certain countries, for example, in Africa, where you have an infection called river blindness. And it's actually used prophylactically, and it's really done wonders in those countries like the Gambia, where before you used to have a lot of people, let's say 30 to and over, going blind from river blindness. When this drug was introduced, it became really a miracle. Hardly you see nowadays anybody who's blind in remote places like Togo, okay, because they've used this drug. And they use it prophylactically twice a year. They'll give it to as many people as they can, and most people will take it, okay? We haven't heard of resistance yet. Maybe it's being used judiciously. And actually, paradoxically, with COVID, what ended up happening, and I was looking at those studies with ivermectin, and what happened was that countries that used ivermectin prophylactically had a much less morbidity and mortality compared to countries that did not use it. So it's widely used as a veterinary medicine in horses, and in fact, when people were using it in America, people were saying it's a horse medicine. So far, I haven't heard of resistance, you know, so I don't know whether it does happen or not, but I'm sure with other antibiotics, definitely, we do get resistance, because many of the drugs that are used for animal husbandry are also available for human use, and there has been resistance developing from those.
Then you have one last question about customs.
Yeah, customs.
I think that's maybe a question for government or someone in government.
So I will have to defer. I will look into that as well. So I can't speak on behalf of the Inspectorate of Health, but I know that they do have protocols and procedures in place for any importation of drugs or pharmaceuticals. And I will follow up with customs to see if there is anything in place for any persons traveling in with drugs. So very good question.
So we have one last question. Yes?
Actually, for Dr. 𝒒𝒂𝒂, do you prescribe antibiotics before or after the culture results and the resistance test? And from what I gathered, we don't have like antimicrobial stewardship. So if you prescribe before the test results, how do you make your choice of antibiotics?
Yeah, so good. So that, I guess, is going to apply for UTIs, yeah, urinary tract infections, yeah. So let's say for, if a patient is having pneumonia, you take the consideration, I mean, you would take consideration the status of the patient. If there are any comorbidity, if the patient is diabetic, you have to be very careful. Is the patient ill or toxic looking? is that anything, can I wait for the culture? No. If it's UTI, let's just stick with UTI. If it's pneumonia, you probably, if it makes you feel like this is a bacterial pneumonia and your physical exam is accurate, the history is accurate, you may start with antibiotics. If it's a urinary tract infection, there is where your proper assessment comes in. You should have a proper history. You should know if this is a first UTI or urinary tract infection. If the patient is none with recurrent UTI, if it's unresolved UTI, what is the status of the patient? If the patient's sick, whether it will present from a simple cystitis or bladder infection. If it's untreated, whether the patient gonna get kidney infection. Now it become pyelonephritis, which is, you don't want that. So your assessment counts. But the way we work in medicine, this is a very good question and very ticklish. We do start antibiotics, and we do tell the patient, you need to go to the lab first, give the urine for culture and sensitivity, and if the lab is closed in the night, that's a little tricky, depend of how the patient is. If the patient is crying and you want to do something about that, if the patient has fever, definitely you want to do something. Not simple UTI should not have fever. So, but then we start empiric, and or we just assume the major bacteria for a urinary tract infection is E. coli, and then we're gonna tackle the E. coli. We're gonna target that E. coli. But then by the time we get, again, if the patient is toxic, if the patient toxic meaning ill, if they're not ill and they can wait until the culture come back, we prefer that. So when the culture come back, you may not even finish your job yet. They may say, yes, but it's not E. coli, it's another bug. You still have to switch. And then they give you how much resistance, and UTIs are very difficult to treat. And so they will be resistant, and then you'd have to use what are then not resistant in order for them to improve. So that is a very good question. And it's a very difficult sometimes with UTIs. Yep. Yeah.
I think that is more for CPS, and yeah, I think this is one of the reason why I'm asking, because I know it is a ticklish question, and the importance of stewardship, and I have sent some emails, try to wake that up, you know, like get it going, because if you have a stewardship, you know, like we work uniform, like the GPs and all the specialists can work uniform and prescribe the same antibiotics for the same diseases or infections. Yeah.
Thank you very much for all of your questions, and of course, thank you to the presenters. I think we will all say it's been a really informative, educational night. So I don't get to say the last thank yous, thankfully. That honor goes to, one second, I want to get your name correct. Dr. 𝒕𝒉𝒆𝒏𝒈𝒕𝒉𝒆𝒏𝒊𝒏𝒈. Okay, Lista. So Miss 𝒕𝒉𝒆𝒏𝒈𝒕𝒉𝒆𝒏𝒊𝒏𝒈, Lista, come to the podium, it's yours.
I said not a doctor yet. A couple more years. Thank you so much. Good evening, everyone. I will keep my closing remarks very short, very brief. But I wanted to thank you for your participation in helping my department, Collective Prevention Services, promote the importance of antimicrobial awareness. For those that are here in person, thank you. And for those who are streaming at home, thank you as well. To Minister Otley, thank you for supporting the department in commemorating this week. Your support is the first step in committing to a national strategy to combat antimicrobial resistance. Ms. Lisanne Charles, thank you for moderating such an engaging session. To the panelists, Dr. 𝒏𝒈𝒕𝒉𝒆𝒏𝒊𝒏𝒈, Dr. Matawi, Ms. Wollenbroek, and Ms. Illis, thank you for your knowledge, your time, and your perspective. This event tonight is a testament to the importance of collaboration, and I want to take this time to also thank Ms. Maria Henry for her endless commitment and drive in leading this work over the last few years, to the University of St. Maarten for hosting this event, to AUC, to the Pharmacy Association of St. Maarten, the St. Maarten Medical Center, 𝒚𝒂𝒄𝒉, and our colleagues at DCOM for disseminating these messages to the community. As the department head of CPS, I hope that we can continue the groundwork that was started some years ago on our national strategies for antimicrobial awareness, as this topic will continue to be relevant in the coming months and years. As a small token of appreciation, I would like to present a certificate of participation on behalf of the Minister of CPS, Minister 𝒕𝒂𝒄𝒉, and I will ask Maria to be my Vanna White this evening to help with handing them out. Thank you so much. I thank you all again for your time, and I wish you and your families a very happy Thanksgiving. Last but not least, Ms. Lizanne Charles. Thank you so much. And I think that's it.
That is definitely it. Drive home safely. Thank you all for coming.